In this video, we'll see cataract surgery. This is the most important in ophthalmology. So first we'll start with our lens, because cataract is nothing but the opacification of your lens. This is the cornea and this is your lens. This is the lens, and this is the ciliary body, and this is also ciliary body. Lens is attached with the ciliary body by suspensory ligaments, which is also called as zonules. So this is the lens. This lens is made up of 35% proteins and 65% water. These proteins are mostly crystalline protein. Therefore, this lens is called as crystalline lens. The lens is called crystalline lens. The location of this lens, in front of the lens, this structure is known as iris, and this opening, this is the pupil, and this is anterior chamber in front of the iris, and this is posterior chamber behind the iris. This structure is known as vitreous. The concavity, this concave-like structure, this concavity is called as patellar fossa. So our lens is placed in this concavity, which is called patellar fossa. So cataract is the opacification of the lens. Lens is made up of 35% protein that are crystalline protein. So the name of the lens is crystalline lens. In front of the lens, we have two structures, anterior chamber, posterior chamber. Behind the lens, vitreous is there. The location of this lens is placed in a concavity, and that concave structure is known as patellar fossa. This patellar fossa lies between lens and the vitreous. If we bring this lens out, then this is the structure of the lens. This outer limiting membrane, this is known as anterior lens capsule, and this is posterior lens capsule. Just beneath the anterior lens capsule, there is one layer of cells, and this layer of cells, which becomes at the end, it is known as epithelial layer. Epithelial layer is present below the anterior capsule. At the posterior pole or below this posterior layer capsule, there is no epithelium. And this posterior capsule is the thinnest. It is the thinnest part of the lens. This is the thinnest part of the lens. So this is anterior capsule, this is posterior capsule, Anterior capsule is having epithelium just below it, but there is no epithelium below the posterior capsule. So posterior capsule is without any epithelium. Posterior capsule is the thinnest part of the lens. If we move inside of the lens, then this is the nucleus. This is the nucleus of the lens. And whatever remaining left part, this part is known as cortex. This part is known as cortex. So this is a simple structure of a lens where you have anterior capsule, posterior capsule, in the center nucleus, and what is left behind is the cortex. This was about the structure of lens. In one PSC exam, they have asked regarding the embryology of the lens. The ectoderm consists of two parts. One is neuroectoderm, that is related with your nervous system, and one is surface ectoderm. So surface ectoderm will lead to formation of your lens. So both options were there. The lens is derived embryologically from the surface ectoderm or from neuroectoderm. Answer will be surface ectoderm. That is the origin of your lens. So up to this, we saw the structure of our lens. Now we'll see there are multiple classification, but based on the stage, cataract is of four types. Incipient cataract. Incipient means it is the earliest stage of your cataract. Because it is earliest, because it is just beginning of the cataract, so there is no or minimum loss of vision. The vision is intact or minimum loss. In this, size of the lens is normal. Because it is incipient, so this is our lens and these are the suspensory ligament. And inside, this is the epithelium and fibers. So what happens in incipient stage, these lens fibers which are inside the lens, these lens fibers, they begin to die. Lens fiber begin to die. Then if lens fiber begin to die, then what will happen? I show you here only. If this is the lens and it is inside concentric layer, these are all fibers. If these fibers, they begin to die, suppose fibers die at this place, then clinically at this place some vacuoles will be appear. If fibers start dying at this area, then what will happen? Some vacuoles will appear like this. And if fibers die at this place, one vacuole will develop like this. So because this lens fiber, they begin to die, clinically, what you find? Vacuoles. 1, 2, and 3. So inside the lens, what you will find? Vacuoles. As time passes, this is our lens. These vacuoles, they keep on coalescing with each other. Means vacuoles, they fuse with each other, and that may lead to formation of structure that is called as water cleft. Water cleft, because the lens is made up of 65% water. So incipient stage of the cataract is the earliest stage. Because it is earliest stage, so minimum or no loss of vision. Because it is earliest, size is normal. Because it is the early stage, so lens fiber just begin to die. Few fibers die here, few here, so they will form small vacuoles. And these vacuoles later on they will fuse with each other and they will form water cleft. So clinically you will see vacuoles and water cleft. So this is the incipient stage of your cataract. After this incipient stage, the next stage of the cataract will be immature. Second will be immature. In this stage, what happens? There is partial opacification. Partial opacification means whitening. Opacification of the lens occurs. The tapetum which is present inside the eyes will give you some kind of reflection if light falls on the tapetum. So tapetal reflex will be present. Clinically, vision is present but during daytime. During daytime, there is some impaired vision. There is some impaired vision that is found in this. So in immature also, lens size is normal. In this, there is no different color to the lens. So these are some features of the immature cataract where the lens start opacifying. Vision is there, but it is impaired during daytime, and if you fall the light on the eyes, then tapetum reflex will be there. Lens is normal and it is having no further coloring. So as this stage further mature, so till now we saw incipient, that is the earliest stage. The next stage was immature, and now the third stage is the mature. Mature stage of in this case entire lens is opaque. Your entire lens is white. No tapetum reflex. Tapetal will not respond to the light. In this case, the entire lens is white, therefore no vision is present. And the most important feature of the mature cataract is the entumescent. Entumescence means swollen of your lens with water. It means this is the cornea, this is the iris, and this is the lens. In the mature stage, what happens? H2O. Water enters inside the lens. Water enters. Because of this water entry, your lens becomes like this. It becomes swollen. Lens become swollen. So in case of mature cataract, where the lens becomes swollen, if this is the cornea, iris, and this is your lens, and if it becomes like this, swollen, so this swollen lens, this lens will push the iris forward. This is the iris. Because of swelling of the lens, it will push this iris forward. If you push the iris forward, then what will happen? This angle, this iris or cornea, which is known as iridocorneal angle becomes narrow. Angle becomes narrow. If angle becomes narrow, drainage will not be there. That may precipitate glaucoma. That may precipitate increase in intraocular pressure. And one more important thing with this stage, because of swollen lens, this angle becomes narrow. Second thing, because of this pushing of your lens to the iris, this this anterior chamber become shallow. It is also become narrow. Shallow anterior chamber. So again increase in intraocular pressure. So if you look at the cataract patient with glaucoma, increased intraocular pressure, it means the lens is swollen, which compresses, pushes the iris, that may lead to narrowing of the angle and increase of intraocular pressure. So clinically, they will be having increased intraocular pressure. So, so the first stage was itself very early stage, we call incipient. Second was immature, and third was mature, where lens become like this, swollen. Now the fourth stage is hypermature cataract. Hypermature. Hypermature means just like overripe fruit. Overripened fruit. In this case, hypermature cataract, your lens is fully opaque. Just like previous, it is white. It is white. Similar to mature, there is no vision. In this case, the fundus, which is nothing but retina, with the ophthalmoscope, fundus is not observable. You cannot observe fundus. The most important part of the hypermature is this. Lens start losing its water. That is the more important. This is the lens. It start losing H2O. It start losing water. If the lens will lose its water, water comes out, then lens volume will decrease, it will become small, or you can say it will shrink. It will shrink. So in case of hypermature lens, in case of mature, it was swollen with the water. But in next stage, like hypermature state, the important thing is this is your lens and it will losing water. So lens will shrink, become small. Not only the lens, if water comes out, then lens capsule, that will also shrink. Lens capsule will also shrink. So lens loses water, becomes small and shrink. Then what will happen? Then what will happen? So this is the cornea, this is the iris, and this is your ciliary body, and it the lens become small. Lens become small, shrunken. Because lens becomes so small, the lens loses its support. This suspensory ligament support is lost. So because of loss of support, lens started shaking. Means lens movement occur because of no support. This movement is also called as lens means phaco. So it is phacodonesis. Donesis. Then because of the movement, because of the lens movement, because of no support, the lens may undergo subluxation. Subluxation, that is nothing but partial displacement. Partial displacement of your lens here or this side. The second is lens may undergo dislocation. Dislocation. Dislocation means complete displacement. That is complete. So the story started with hypermature, water comes out, lens becomes small, it loses its zonule support. Because of that, it started moving. Because of that movement, it may undergo partial displacement or it may separate from here and may fall in this area. That is dislocation, complete displacement of the lens. So lens may displace partially or completely. This hypermature cataract is of two types. Hypermature. If this hypermaturity, if cortex of the lens becomes hypermature or nucleus of the lens become hypermature, then the terminology is different. When cortex become liquefied, hypermature, then it is called Morganian cataract. If nucleus becomes hypermature, become hard, then it is called sclerotic cataract. So these are the terminology under hypermature. If cortex becomes hypermature, Morganian, and if this becomes the sclerotic cataract. So first we'll see what is Morganian cataract. Hello, voice is clear, no?
Okay.
So first is Morganian cataract. Morganian cataract means hypermaturity of cortex. So cortex becomes hypermature. Cortex becomes hypermature. Cortex becomes liquefied, but not nucleus. Nucleus is intact. Only cortex becomes liquefied. So if cortex becomes liquefied, this is the lens, this is the nucleus. If there it becomes like watery liquefied, Then, because of gravity, lens settle inferiorly. Lens settle in this inferior direction because there is liquid below this. So because of gravity, the cortex becomes, because of hypermature cataract, cortex becomes liquefied. Because of gravity, the nucleus is intact, it floats and then it settles down inferiorly. So the characteristic feature of Morganian cataract is cortex becomes liquefied and lens float or lens settle down, sink inferior. So the concept of Morganian, it is called a bag of a bag of milky fluid, a bag of milky fluid with nucleus floating inferiorly. This is your Morganian. This is your Morganian cataract. A bag of milky fluid where nucleus is floating. This is the lens, this is the nucleus, and surrounding part is cortex. If cortex becomes liquefied, then it will settle inferior. So it is a bag of milky fluid. Milky fluid is cortex. So bag of milky fluid where lens, this nucleus is floating inferiorly. Why inferiorly? Because of down gravity. And then the other part of the hypermature is sclerotic. That is the nucleus become hard like a stone, and it is seen in case of old age dogs like more than 8 years old. So till now, what we see, cataract stages. First was incipient, second immature, third mature, fourth hypermature. And hypermature is also of two types. If cortex is hypermature or nucleus is hypermature. Cortex is hypermature, we call it Morganian. And if nucleus, then it is called sclerotic. So this is the cataract classification based on the stage of development. So what happens in case of mature? In case of mature one, lens becomes swollen because of entry of the water. And that may push the iris, becomes increase in intraocular pressure. And what happens in case of hypermature? Lens loses water. So it will become a small and shrunken lens. That may lead to the luxation or complete dislocation of your lens. Other classifications like juvenile, adulthood, cataract, and drugs, diabetes, they are simple to read. But these cataracts were important for surgical point of view. So, now surgical corrections. What options we have? First is intracapsular cataract extraction. Second will be extracapsular cataract extraction. Third is Phaco emulsification. Phaco emulsification. These three are very important. Other like flex, they are in human being, MICS, they are used in human beings. So we'll see intracapsular, extracapsular, and phacoemulsification. These are the procedures in which here only this is not recommended for the cataract surgery. Only one indication is to correct luxated lens. If there is luxation of the lens, then to correct that, intracapsular cataract, this surgery is used, but not for cataract. This extracapsular is used, this phacoemulsification is nothing but a type of extracapsular cataract extraction. So first we'll see the intracapsular. So first surgery is your intracapsular cataract extraction. In this case, there is removal of lens. Removal of lens. It's better to say removal of cataract. Removal of cataract. There is removal of anterior lens capsule and there is removal of posterior lens capsule. So everything is removed, intracapsular. So not only the lens, its capsule is also removed. Lens is also removed and along with the capsule. This is your cornea, iris and ciliary body, and this is the lens and this is the cataract. So if we look at the ICCE, then this is the cornea, iris, whole lens is removed, behind this only retina is left. What is this? Retina. So this lens is removed along with the capsule. This is your intracapsular cataract extraction. Means there is, if lens is removed along with the capsule, that situation will be called as aphakia. No lens. No lens. Why this surgery is not preferred? If we look at the cornea, this is iris, this cornea and this is the lens. Light rays fall on cornea, cornea bend them at the lens, lens will further bend them and they will fall on the retina. They will fall on the retina, which portion? Fovea. Okay. This bending power of cornea is 19 diopter, and this, not 19, it is 43, and the bending power of the light for the lens, it is 19 diopter. So if we combine these two powers, cornea or lens, 43 plus 90, approximately it will become 60 diopter. That is the power of human eye. So there are two surfaces to bend the light. One is cornea, one is lens. Cornea is having more power to bend the light than lens. The power is 43 diopter. Lens is having less power, 90, which makes total power of eye is 60 diopter. So in case of what happens in case of intracapsular cataract surgery? This is our cornea and iris. This is lens. This was the normal, where light falls on cornea, it bends on lens and that will bend on the focus on the retina. After doing intracapsular cataract surgery, this is the retina or cornea. There is no lens. There is no lens. Now what happens? In this case, this cornea is giving 43 diopter and lens was giving 19 diopter. When you remove the lens with the capsule, now there is only 43 diopter. This cornea will bend the light. This light, but there is no lens, no 19 diopter, nothing here to bend the light, so it will become like this. Your light will not focus on retina. It will go behind the retina. This is the problem with the intracapsular extraction, where you remove the lens, cornea is there, it will bend. How much it will bend? Whatever power it is having. So it is having 43 diopter, it will bend, but no lens, nothing to bend, so it will go behind the retina. So image will form here. So in such situation where the image formed behind the retina, what is compulsory to use is your lens, glasses. If you use convex lens, if you wear the chashma, then the convex lens, it will bend the light, remaining will be bent by the cornea and then it will focus on the retina. But problem with this convex lens always do magnification. The limitation of convex lens is the magnification of the image. Magnification of the image. It means these are two eyes. This eye is having cataract, you removed and you applied, you are wearing convex glasses. Convex glasses will focus on the retina. But the problem with lens is magnification. Magnification. The image becomes magnified. This is your normal eye, normal lens, normal retina. It will focus on the retina. Inside the brain, from these two eyes, information will go and image will be perceived. Because of two types of image, this is normal, this is magnified. So the condition will arise with the patient will be diplopia. Diplopia means double vision. One eye is normal, but it is seeing the things magnified. So the problem with the intracapsular cataract removal is no lens, aphakia, You apply glasses, but they have limitation of magnification. Both images went to brain. Brain reads the images, and one will be read as magnified, one is not. So diplopia, two types of vision becomes double vision or diplopia. So this is not recommended for the cataract, but previously it was used. One more problem with this intracapsular extraction was this is cornea, iris, retina. There is no lens. There is no lens. So what will happen? This iris will fall this side. This eye is the iris. It will fall backward because the support, the lens support, it is not there. If you remove the lens support, iris will fall backward. Then what will happen? Cornea, this is iris. If this gone backward, it will become like this. Anterior chamber will become more deep. This is the iris. Anterior chamber become more deep. So this surgery, intracapsular, it started with large incision. That is also that may lead to, if incision is large, that may lead to corneal ulcer and all problems. Second was diplopia, double vision. Third was deep anterior chamber. So it is not recommended. Only indication is you can use for the to correct luxated lens. If lens is luxated, which is having no support, remove. The second surgery is extracapsular cataract extraction. In this case, cataract is removed, but anterior lens capsule, posterior lens capsule, they are intact. Anterior lens capsule, a small part is cut. Small part is cut to bring that out. So, in this case, cataract removed, but capsule is left. Suppose this is my cornea with iris, this is ciliary body, and this is the lens. And this lens is opaque white. So what happens in this surgery? This is the cornea, iris. Make a small hole or nick in the anterior lens capsule and will bring all this material outside, all cataract outside. So this capsular bag, it is present. Capsule is present. So this bag, this capsular bag is there, only what we remove the inner content. Cataract part is removed. So this is case of the. So the advantage of this surgery over intracapsular is that we can use some artificial lens. This is the eye with iris, and we have capsular bag. So if you have artificial lens with you, now they are called as intraocular lenses. Artificial lens is intraocular lens. So if you have a lens with you, you can place that lens into this capsular bag. So this facility is there. In intracapsular, we were removing both lens and capsule, but here capsule bag is important. It is there. So if there is no capsule, where you will place your IOL? That facility is there in extracapsular. So these intraocular lens, they are of two types. Previously, they were using PMMA and it was more commonly used. But nowadays, they are using soft, flexible, foldable lenses and they are acrylic. They are acrylic lenses, acrylic hydrophil. They are acrylic. These were hard. You cannot fold them. So these are the lenses material they were used. In which species and what is the power we have to use? So intraocular lens we are using for horses, dogs and cats. They are available with some power. In case of horses, 14 diopter or 21 diopter. In dog it is 42, cat it is 52 diopter. These are the IO available. So we can place artificial lens in the capsular bag. In the capsular bag. If you look at the structure of one intraocular lens, the central part, this is the central part. It is known as optic. It is known as optic. These two are hooks, and these hooks are known as haptic. These two are known as haptic. So this is your IOL, and this is my cornea, iris, ciliary, and this is the capsular bag. So we'll keep this intraocular lens inside. Like this is the central part and this is hook, this is hook. The role of hook is just to hold it in proper place. So in this way we can place our lens. The role of this lens is because some power is contributed by lens and some power is by the cornea. Now the image will form on the retina. So this was about extracapsular, where we remove the cataract, leave the capsule, and we can implant intraocular lenses in the capsular bag. So the most commonly used technique in this category is your Phaco emulsification. Phaco emulsification. First, I'll tell you the principles, what we are doing in this technique and the steps of the technique. This is most common. So in this case, phacoemulsification, this is the cornea, iris, ciliary, and this is my lens. It is attached. Okay. So what we are doing, this lens, Phaco means lens and emulsification means we have ultrasonic probe which is nothing but made up of a titanium. We hit the lens, this is the lens, we hit with a probe 40,000 times per second. The lens will become just like a powder. It will just like a powder. Means lens become emulsified because of this heating. If lens becomes, this content, cortex, nucleus, everything becomes emulsified, then This becomes emulsified. This is the cornea and ciliary body. Then this content is aspirated outside. This content is aspirated from the anterior capsule, nick or hole. We aspirate it outside. So this is the principle. Lens is broken down into pieces, powder form, and will take it out. That is your Phaco emulsification. How this Phaco emulsification surgery is done? What are the steps? How to move or enter inside it? Phaco emulsification. First is your general anesthesia. Use isoflurane. It is recommended. If you use others, then I will become like this. It will become ventromedial. In that general anesthesia, it will become ventromedial. So that the recommended is the isoflurane, general anesthesia. So after anesthesia, the main steps of this technique, Phaco emulsification. Phaco. First is incision. First, how to enter in the eyeball. How to enter. Second, if you enter, then capsulorhexis. Rhexis means tear. If you enter the anterior chamber, capsule is there. Inside capsule, lens is there. So first you will make a small cut in the capsule, then will start breaking down other things. Hydro techniques. Hydro procedures. There are two hydro procedures. Hydro means water. So these two are hydro dissection. We dissect something, and this is hydro delineation. The fourth step is Phaco emulsification, and fifth is cortical aspiration. After you make it powder, aspirate it. Aspiration, and the last step is, so once you remove all the content of the cataract, capsule bag is there. Now you can place your intraocular lenses, and after placing your intraocular lenses, close the incision. So these are the steps. First we take the incision, at the end we close the incision. So we'll look at this step one by one in Phaco emulsification. First is incision. Where to take incision? This is cornea, iris, and this is the sclera. And this is cornea, and this junction is limbus. So the preferred is either peripheral cornea or limbus, that is junction of cornea and skull. So you can take incision at these two places. What happens if you take your incision at sclera? Sclera is more vascular, more blood supply. So if you take incision, it might happen there may be bleeding, hemorrhage. If you take one incision here, vessels may bleed, and what will happen? After hemorrhage, blood may enter into your anterior chamber, and that is known as hyphema. That is known as hyphema. So because these vessels are there, sclera rich of vessels, if you make incision, that may bleed. If they bleed, blood may come out into anterior chamber. Everything becomes red. At this place of time, you cannot see other structure like your capsule and lens because of this blood here, because of this hyphema in this anterior chamber. So this is avoided. Sclera incision is not given. Either peripheral cornea or limbus. This was about the incision. Second step, okay, this is cornea. Suppose we are entering from this point. We made something like 2.8 mm incision at limbus. You enter. Now you are in the anterior chamber. During the whole procedure of surgery, it is necessary to make the anterior chamber do not collapse. Your anterior chamber will collapse. So how to inflate? How to inflate it? Whole surgery. You will put some hyaluronic acid. Hyaluronic acid. They are viscoelastic agent. They are viscoelastic agent. They will make it open throughout your surgery so that you can enter, you can bring the lens material outside through the incision from where you went and from here. So it will not collapse. See, if you make a cut incision and the anterior chamber it drains out and it collapses, then it becomes difficult. So don't make your anterior chamber collapse. Keep it inflated with the help of hyaluronic acid like viscoelastic agent, or you may use CMC, carboxymethyl cellulose. But this is 1% hyaluronic acid, more important. Hyaluronate, sodium salt. Huh? So you entered, you inflated your anterior chamber. Now, the next step, we are moving towards the capsule. So the second step is your anterior capsulectomy. We make a tear, we make a nick in the anterior capsule. The method how to make is known as triple C. Triple C. This is continuous curvilinear capsulorhexis. Rhexis means tear. So this is continuous curvilinear capsulorhexis. It means, what is the meaning of this triple C? This is the lens. If you look at from the dorsal surface, you will see in three-dimensional. If you see from the dorsal surface, you will see anterior capsule because behind this is posterior. So continuous means once you keep your instrument, don't remove it in between. So continuous means start like this in circular manner and cut like this. This is continuous curvilinear fashion. So in this fashion, what we are doing, we are making one hole, one nick in the anterior capsule. this hole is created, and the size of this hole is 5.5 mm. This is created. So where we are going into the capsule. We make one hole in the anterior capsule, capsulorhexis, anterior capsular cavity. The next step is hydroprocedure. Hydroprocedure. First is hydrodissection. What we are using, balanced salt solution, we inject here just below the anterior capsule. The role of this salt solution, this hydrodissection, is to separate anterior capsule from underlying cortex. We want to separate this capsule from the cortex, or you can say we want to separate cortex from the capsule, because with the help of that probe we will hit the cortex and will make it macerated, pulverized, or small pieces, make it powder and will bring out. So first we remove, because it is attached with the capsule. So to separate this cortex from the anterior capsule, we inject some solution, balanced salt solution. That is hydro, with the help of watery substance, dissection, separation of anterior capsule and cortex. Then one more step with this procedure was hydrodelineation. In this, the nucleus is split. Nucleus is split into two parts, outer and inner part. Just to make the procedure simple, or to separate these things, we are doing this hydro procedure. So to split the nucleus. So up to this step, what we did up to this step, this is the capsule, anterior capsule. We made a hole and we have separated the cortex from the capsule, and we also chopped the nucleus into pieces. Now what we do? Now the step is Phaco emulsification. Emulsification. With the help of that titanium probe, which will mechanically hit the lens 40,000 times per second, if you hit something, this material, if you hit something at this frequency, it will become just like powder. It will become powder. So this powdered material, we have created one nick here. So we'll bring this material out like this. And this procedure is called aspiration. We aspirate the things. It is easy to aspirate in this part. So this was the simplest procedure of Phaco emulsification. So if I revise in one diagram, this is cornea, this is the eye, and this is the iris, and this is the lens. Okay. So this is the limbus. First we made incision, we enter, then we'll put in the anterior chamber some viscoelastic substance like hyaluronic acid, carboxymethyl cellulose. They are viscous. They will not allow it to collapse. After this, we enter more. We make one nick here, capsulorhexis, anterior capsule is there. Then this lens cortex was attached firmly with the capsule. We did hydrodissection. It is separated. It is separated. Lens was also, nucleus was also broken down. After this, we put our probe like this, and that probe will make it fragmented pieces. After that, with the second hand, you can aspirate this nucleus, this cortex and nuclear material, aspirate out. So what are there are two complications which are most common. One complication is during surgery, that is intraoperative, intraoperative. And one is when you send the patient to the home, that is post-operative. So during surgery, during operation, the most common complication is your rupture of posterior capsule. In the beginning of the lecture, I told you this part of the capsule, it is very, very thin. So there are chances that during this doing triple C or making capsular access, you may tear this part. So rupture of posterior capsule is most common because it is thin. Second is after operation, post-operative is the PCO, PCO. Posterior capsule opacification. Posterior capsule opacification, and it is also called as secondary cataract. Cataract because of surgery. This may become opacified. So both the complications, they are related with the posterior capsule. Either it may rupture, tear during the surgery, or after the surgery it may become opacified. Posterior capsule opacification. So this finishes our today's lecture about the cataract surgery, where we saw three techniques. Intracapsular removal, extracapsular removal, and we saw the Phaco. These three surgeries. In this case, this was cornea, iris. This is retina. We removed the lens along with the capsule. But in this case, cataract is removed, but capsule is there. If capsule is there, you can place your intraocular lens. In this Phaco, this is cornea, iris. Same, one nick is there. It is emulsified powder and bring out. And now you can place intraocular